Welcome everyone to AAC and the IEP webinar on Wednesday, February 15th at 6:30. Guest presenter is Kristin Ellis, a speech pathologist and argumentative alternative communication specialist, hosted by the ARC of Lehigh Northampton Counties. Our disclaimer is the ARC of Lehigh Northampton Counties Advocacy Department does not employ lawyers nor provide legal advice. This training or any other provided by the ARC Advocacy Department does not constitute or imply the endorsement, recommendations, or favoring of the providing party or any employees or contractors acting on its behalf. This webinar is being provided for educational and informative purposes only. Now I have the pleasure to introduce our guest presenter, and I am going to read a quick bio so you now know who she is. Kristin Ellis established her private practice Time to Talk therapy service back in July of 2020 out of a growing need for speech language services in the surrounding areas. She received her bachelor's and master's at East Stroudsburg University. Kristin holds a speech language pathology license through Commonwealth of Pennsylvania and holds a certificate of clinical competence CCC with the American Speech Language Hearings Association. Kristin has worked in several public schools in both northeastern and southeastern Pennsylvania. Kristin has also worked in varieties approved private schools and specialized in educating students who are blind and visually impaired, have a diagnosis of autism paired with behaviors, and to have a history of social and emotional disturbance. She is also a full-time employee of Behavioral Health Associations, which is an approved private school in Carbon County, PA. Lastly, Kristin is the director of speech therapy department and the argumentative and alternative communication specialist of all the BHA schools. Thank you, and the Zoom is yours.
You did good. There's lots of long words in there.
Yes, there is definitely a lot there.
I know. So welcome to AAC and its role in the IEP. As Kodi said, my name is Kristin Ellis. I'm a speech language pathologist and an AAC specialist. And you are all here at the ARC for Lehigh and Northampton counties this evening to learn a little bit more about AAC and just my niche and my love. Bear with me because it is the evening time and I talk all day for a living, so I will be drinking water periodically, so please bear with me. Just a little bit about me. I'm not going to kind of redo all of this because it was already mentioned by Kodi, but you know, I have my bachelor's and my master's degree from East Stroudsburg University. I've worked in a variety of different schools, including public schools, charter schools, and approved private schools for varying diagnoses. I've also worked in a variety of different healthcare settings as well. I get the best of both worlds, including outpatient clinics, home health, and more recently, I've been promoted at BHA to be the director of speech therapy and the AAC specialist within all of BHA schools. And as Kodi mentioned, my private practice has been around since 2020. COVID, people were looking for services and it kind of bloomed out of not much of anything. Just a few disclosures, just because I present for ASHA and other organizations, I have them in here, that I am a full-time speech language pathologist and AAC specialist with BHA, so I do get a salary from them. I'm the owner of Time to Talk Therapy Services, which is my private practice. I'm the organizer and developer of the Everyone Deserves a Voice AAC Summer Camp. And my non-financial disclosures is I'm a member of ASHA, an affiliate of SIG-12, which is related to AAC within ASHA, and I'm a member of USAC and ISAC. Okay, so where we're going to get started tonight is what I've coined now the 5 W's of AAC. In the realm of speech language pathology, we talk a lot about the 5 W's, which are the who, the what, the where, the when, and the why. And I thought this was a great way to kind of segue into a little bit about AAC for those of you that may not be as familiar with AAC or augmentative and alternative communication. You know, so what is AAC? You hear that term kind of thrown around a lot. It's an area of clinical practice that supplements and compensates for impairments in speech and language production and or comprehension, including spoken and written modes of communication. AAC falls under that broader umbrella of assistive technology. A lot of times when people hear the term assistive technology, they automatically kind of go to the high-tech AAC devices on the tablets, and that's actually not true. Assistive technology encompasses everything from pencil grips to slant boards to wiggle cushions to putty and things like that, you know, all the way up to your high-tech communication devices. Assistive technology is basically any equipment, tool, or strategy that's going to improve the functional daily living in individuals with disabilities or limitations. So within that, AAC encompasses a variety of different techniques and tools to help an individual express thoughts, their wants and needs, their feelings, and their ideas. So that can include manual signs, gestures, finger spelling, tangible objects, line drawings, picture communication boards, like you can see in the picture behind you, some core boards, letter boards, and of course, speech generating devices, which is kind of what drew a lot of you in this evening. AAC is referred to, you know, it's made up of this augmentative and alternative within its name. Augmentative is when we're using it to supplement existing speech. So these could be kiddos that maybe are highly unintelligible. They have a lot of speech sound errors. It's hard to understand them in conversation when they're talking. It also, on the other end of that, can be my kiddos with a diagnosis of autism that are extremely scripted. And they kind of stay within their scripts and we can't get them much further out of that. So we might look to use an AAC device to get more spontaneous communication. The word alternative refers to when we're using an AAC device in place of speech that is either absent, it's not functional, or it could be temporarily unavailable, you know, post-operatively or something like that. AAC can be no tech, low tech, mid tech, or high tech. And what is all of that? There's lots of tech words going on. I'm getting very confused, Kristin. What is all of this? So no tech and low tech tend to be the boards that you saw in the last picture that were up on the wall, or they can be flip books like this here that kind of it mimics a high tech system, but it's low tech. They're the beloved communication books or the PECS books, the picture symbols, icon-based communication. You know, these have no tech, there's no batteries, there's no charging, there's nothing involved with them. You know, you can print them, you can copy them, and there's not much involved besides some time related to that. Yeah. There we go. Our mid-tech devices are kind of just as they sound. They're the middle of the road devices. So they give you voice output. They can be a little bit cheaper than the high-tech devices, but they can still be limiting. And maybe that's like the switches here, the Big Mac and the Little Mac. They are limited to single messages, but they have to be programmed by communication partner. And if you want to change those, you have to record over top of them again. Up in the corner here, you have a Go Talk 20, which is just a static display where you're kind of making the images on an overlay, and then you're sliding it into the side of the device. Now this one does have multiple levels that you can program, you know, and have kind of working 5 different pages, but then you'd have to record over top of those again in order to do any more. And then another example is a Logan Prox Talker, which a lot of people have kind of equated to more like talking picture exchange. And that's what that one is over here. But again, requires programming, a lot of assistance from communication partners to kind of control these methods. So Sometimes these are not items that tend to be thought of in the realm of AAC devices. It might be the starting point, but not necessarily the end point. And then what everyone kind of knows it to be when you talk about AAC, it's these things right here. The tablet-based communication, the things that are up on mounts on children's wheelchairs. These tend to be the high-tech devices that everyone's kind of thinking about. You have the accent systems from PRC Saltillo. You have the Tobii Dynavox devices. You have the SmartBox GridPad 10S. And then you have the Nova Chats from PRC Saltillo as well. Tend to be just some of the high-tech devices. A few others will be mentioned later on, but it just gives you an idea of how many things actually are out there when people are asking the question of, well, why does it take so long to get this device in certain settings? And part of the answer to that is that there's so many things out there. And many people are not well versed in everything you see on the screen before you, unless you've had the exposure through that's the kind of work that you do. But we'll talk more about that. So we talked about the what, but here comes the who. Who is eligible to use AAC? And this is the one where I always get hung up on with individuals where they're like, well, this person can't do it and this person can't do it. There's no can't. Everyone, people of all ages can use AAC. They have trouble with speech and language skills. Some people use AAC throughout their life, but others, they might just use AAC only for a short period of time. And those are some of my 2- and 3-year-olds that they are new to a diagnosis of autism. We decide to get them on an AAC device, and then in 2 years, they're talking. And I've seen it happen. It happens. Does not happen with everybody, but it happens. There's no minimum age or maximum age to introduce someone to AAC. They can be, the youngest person I have right now is a 1.5-year-old, and the oldest I've had is 57. So there's really, it's one of those things that, you know, our way to communicate can be gone in an instant. You know, any one of us sitting here this evening could have some type of accident that impairs our ability to be able to speak. And AAC can be used for everybody. There's no prerequisites for someone to use AAC. They do not need to understand certain things in order to be exposed to an AAC device. They don't need to identify from a field of pictures. They don't need to be able to do XYZ of doing cause and effect and being able to label a bunch of things, have so many certain verbal words. They don't have to have a certain IQ. All of these things are common misconceptions about who can actually benefit from an AAC device. So you can move on to the where. Where do we get AAC? Where does it come from? A lot of people can get it from their school district. Maybe a local intermediate unit can help with it. Outpatient clinics, hospital clinics. These are places you can go to kind of go through that evaluation and funding piece of it that we're going to get to a little bit later on. Some of these are the companies that, you know, personally I've worked with as well that can supply the devices once all of the legwork is done through one of the 4 listed entities on the slide here. You know, devices can be obtained through AbleNet, through SmartBox, through Talk to Me, Dynavox, PRC Saltillo. And again, it's another thing that makes the waters very murky, and it's hard for some people to navigate because there's so many things out there. Why does a child need AAC? You know, we're specifically going to talk more about, you know, children this evening, but it kind of applies to anybody. But, you know, we do it so that we can establish a means of communication and social interaction. We get a device to promote language development. We get a device to support cognitive development and their learning. We get a device to enhance work and educational opportunities. We get a device to facilitate speech development. We get a device because we want to clarify the speech production that a child already has, or we get a device to enhance the participation in society. You know, and I love the photo that's on here. I get teary-eyed every time I see it, that these two individuals have kind of come together and that they never would have met if it wasn't for their AAC devices. They never would have been friends because they live in totally separate areas of Pennsylvania. They never would have met. And now they are like best of friends. And, you know, I think one or both of their moms may be on with us tonight. And, you know, I'm sure they'll chime in at some point and say that, you know, it's been life-changing. And AAC can be life-changing for the child as well as the family. So when is the right time to get AAC? I always kind of throw out, if not now, when. It's kind of like the same thing of like, I don't think it's the right time to have a baby. It's not the right time to have a baby. But is there ever really a right time? Is there the best time? AAC should be considered for any child when their speech output is not adequate to communicate everything that the child wants and needs to communicate. Not what we think they want and need to communicate, what they want and need to communicate. So some things that we should be considering is the child's frustration level, the adult and the family's frustration level, their access to their school curriculum. You know, these are potential barriers or hurdles that are kind of that we run into when there's a lack of communication. You know, what's their participation like in classroom activities? What's their ability to demonstrate knowledge to their teachers and, you know, show us kind of what they know? Not testing, we're not testing, but, you know, what do they know? Access to their home and their community environment, their ability to interact appropriately with family and peers, their independence in developmentally appropriate daily activities. You know, what are the hurdles that we're experiencing, and what are your answers to some of these bullet points? And if you're feeling some of these bullet points, the time is now. Like I said, there's no age minimum. So once we've kind of met all the 5 W's, the who, the what, the when, the where, you know, the why, then we have to move into, you know, you're seeking this process out. We move into the AAC assessment process. And again, I have graphics kind of all over here that kind of show all of the things that tend to be within this spectrum of AAC, and continuum of AAC, all the way down from your manual boards all the way up to your high-tech devices, with some with alternative access, eye gaze and head tracking, switch access, things like that. And when you're going into an AAC assessment process, when a name first comes across my desk, all of these things are still on the table because I haven't met them yet. I might have some information, I might have an IEP, I might have I might have had a phone call with the parent, but if I'm just getting a name or I'm just getting a referral from a school district to complete the process, I don't really know quite where I'm going yet, so everything's still on the table. So there are a bunch of different steps within the AAC assessment process that can be confusing, overwhelming, frustrating for those that aren't familiar with it. So step 1 is a functional communication assessment, which, you know, if we have any other SLPs on here, it's your traditional speech and language assessment. You know, that you're obtaining data through standardized assessments, or standardized checklists that you're giving to family members or teachers to complete. One of my favorite standardized checklists is it accompanies the RESCA, and it's the social communication inventory. All of my clients have received it, and their parents and or their teachers have completed it in order to give me an idea of where their social communication. So same elements that you have in a traditional speech evaluation also encompass functional communication aspect of an AAC evaluation. The goal is we want this full picture of their receptive and expressive communication skills. It's a combination of formal and informal strategies, including parent interview and observation, what kind of communication skills are already there, what kind of challenges and needs are present of the communicator. How does current communication compare to what the developmental expectations are of someone that same age? You're also going to be looking to gather information on their vision, their hearing, their fine motor skills. And when available, cognitive ability as well. Not that I put much stake in the numbers related to cognitive ability, but it does give you additional information. Some of the standardized assessments I like to use are the vocabulary. I like to use the RESCA that's associated with the social communication inventory. The reason I like that is because a lot of children that are limited verbal or nonverbal can still participate in a lot of elements of that test, which result then in standard scores. One of my go-tos for some informal information is the AAC Evaluation Genie, which has many tiny little subjects within it, including, verb vocabulary, noun vocabulary, category inclusion, category exclusion, their ability for word precision and word reading. Do they recognize core vocabulary? Do they recognize some of the unity symbols? And it just gives me an idea of some of the skills that are there.
Hey, Kristin.
Yeah.
Hi, sorry. My name is Jessica. I wasn't here in the beginning. I'm the director of advocacy at the ARC. I just want to pop in. We are having a little bit of trouble hearing you. You're kind of cutting in and out recently. I'm not sure if it's the distance between you and your microphone or and we just had a question that just came through that was, you're breaking up a little bit. What was the profile you said you use for everyone?
But the profile I give to all of my kiddos is the social communication inventory, which is this one, the third one on the right here. It's part of a bigger assessment called the RESCA, but you can do it standalone or with the RESCA standardized assessment.
Perfect. Thank you.
Yep,
Okay.
You're welcome. Okay. So then after all of that kind of is underway, which can take some time in and of itself, that's when we start to go to comparing AAC system features to the child's needs to determine what language system, what access methods, and what tech features might be needed. We call it feature matching. And determining this is supposed to be a team decision as well too, as to what will they need at school, what are they going to need at home, what will they need in like their individual speech therapy sessions as well. So do I need high contrast symbols because the child has CVI, cortical vision impairment? Do I need a device that is accessible via eye gaze? Do I need a device that is accessible via head tracking? And these are all the kinds of different things that we have to think about when we're kind of figuring all that out. Are we doing a dedicated device? Are we doing an integrated device? A dedicated device, for those of you that don't know, is a system that's completely locked, meaning that it only has the communication software available on it, and that is it. An integrated device and a dedicated device is funded through insurance or can be bought out of pocket. An integrated device is one that is unlocked and is capable of browsing the internet, sending emails, sending text messages, things like that. An integrated device and insurance will not fund when it is integrated. It needs to be dedicated, which we'll talk about a little bit later as we're getting towards the end of this long process. Something else that we have to decide is, what's the font size I need? What kind of text do I need? Do I want a keyboard available? The ability to hide and mask keys. Do I want something that is single words? Do I want something that has phrases and sentences? So we do this and we compare a bunch of different devices. A lot of times you'll hear a lot of people throw out 3. That's the number. That's the magical number, 3 devices, that you're going to put 3 devices in this device 1, 2, and 3, and you're going to check where all the boxes fall and find which one has all the things that the child needs or checks the boxes of everything they need. From there, we get to go forward with trials. With what are we going to trial? And in order to trial, now we have to customize. We have to customize the device or the software program to match what we want it to look like. So this means how many buttons do we want available? Are we going to do touch chat 25? Are we going to do touch chat 60? And there's a difference between the two with what's available on the home screen and what is not. What kind of vocabulary selection are we going to have? Are we going to use the symbol sticks images that are on here, or are we going to import the board maker PCS symbols? Are we going to take actual photographs? All of that has to be done, and the legwork has to be done in order to trial the device. Any interface features that we want it to be able to do eventually. Does it have the capability of controlling Alexa? Does it have the capability of browsing the internet in the future if we want it to do that? Does it have the access method available that we want it to? And then setting up that access method. So in the land of switches and alternative access, which I love that these are all the different types of switches that maybe a user can use to access their device. You know, so are we doing 2 switch access? Are we doing 1? Do we need a pillow switch that is like by their knee that they can do that? And then we're going to mount all those things if they're in a wheelchair or something like that so they can access. And we're going to teach them how to do that. Which this is where the long part tends to be, is this trial period where there's a lot of misconception on how long it should be, how many things need to be tried, and then what it looks like after that. So the short answer is that insurance companies like to see that you have considered 3 devices. Considered. Not trialed necessarily, but considered. You can rule things out in based on the feature matching we did in step 2 without having to physically give the child the device and have them fail at it, or show us that they can't do it, or we create a behavior. A lot of my students are on the autism spectrum. If I present them with something I know that they're not going to be able to do based on feature matching, I'm going to get a behavior, and more than likely it's going to get thrown at me. I might get scratched, I might get bit, and I'm not going to I will not present my students with something that I know is going to create a behavior. If I know that they have dexterity issues, I'm not going to present them with something that has 1/2 inch by 1/2 inch buttons and that I can't change the size. So now that we did all this lovely customization, now we get to trial it. They do say that we should trial more than 1 system with them. Focus a lot on aided language, input or modeling. Our job as the SLPs is to take lots of data. This time frame can range typically anywhere from 4 weeks to several months, depending on the way that you're trialing and where you're trialing your systems. And supporting the family on the device as well, how they can model it at home, and coaching them through what that kind of looks like. I like to talk to my families and send trial devices home and hear how things are going at home, as well as in my 4 walls in the clinic. My 4 walls in the clinic is, you know, a created atmosphere, where at home is more natural. So I like to send my devices home for them to try and see how they do. Step 5, the fun one, funding, and how we're going to get the actual device. The goal is to give everyone a voice. There's the option of school funded versus insurance funded. The difference between the two: if the school funds it, they own it. If your insurance funds it, you own it. Therefore, if the school owns it, they dictate what happens with it. when it goes home, when it doesn't go home, when your child graduates or leaves the district, it doesn't go with them. Insurance, if it's yours, it's yours. If you pick up and move to Florida, it's going with you. The problem with insurance funding is that there's a couple extra things that have to happen. There's a lot of ducks that have to be in a row and have to be the correct way for all of the insurance companies to be like, okay, yeah, I'll pay for that. You need that AAC assessment that we just did several slides ago, completed by a speech language pathologist. It can't be done by a school psychologist. It can't be done by a medical doctor. It can't be done by a special education teacher. The evaluation needs to be completed by a speech language pathologist. You need to have all of the insurance information in order. This means if there's a primary insurance and a secondary insurance, I have lots of families that are like, well, I just give the secondary for everything. No, that's not how it works. I need everything because when it's run, it's all flagged. It all needs to go. There needs to be a physician prescription form. So I'm the one recommending the device, but an actual medical doctor needs to sign off on the actual prescription form that goes with all the funding packet. And then there's a couple of signed forms that the parents or the caregivers need to complete that just say that you're allowing the company to bill the insurance for said device, you know, that you're responsible for any co-payment that may be there or any deductible. I threw a bunch of the primary insurance companies specifically that are popular in Pennsylvania, all of which I have funded communication devices with. And all of the state MAs as well. All of the MA plans that fall in line with all of these companies as well will also cover. There are a few exceptions to that, but if you have one of those insurances, it's written in plain black and white already in their big packet of information that says what they cover and what they don't. And it will strictly say they don't cover speech generating devices. I've only encountered that once in my entire career. And for those situations, there's alternative funding options out there, including grants and things like that. Okay. That brings us to, now we have the device. Now what do we do? Well, now we have to get it in the IEP, which is super important. So there are several sections of the IEP that are influenced by having an AAC device. So I have them listed here. We're going to go through them one by one as well. So section 1 is the special considerations section. Section 2, present levels of academic achievement and functional performance. Clearly the goals and objectives, the specially designed instruction, supports for school personnel, related services, and extended school year or ESY. Special considerations. This tends to be one that there's so many issues with because the box is never checked. It's this box down here that says, does the student need an assistive technology device and or service? It should be checked yes. A lot of my students, before I kind of get involved, this is checked no, and it should be checked yes. And anything that is checked yes up here, this is also the blind and visually impaired and behaviors, all of those things are in this section. They are then talked about later on throughout the rest of the document. It also will pop up depending on the type of IEP system the school district is using. It will pop up a little box underneath that you can actually put some notated things in there as well. Sometimes my special ed directors I work with will say like see whatever section of the IEP. They might just put a brief description of C information, on communication device mentioned in certain section as well. That's not going to be the section where you're going to have tons of information about the device. Okay. The present levels of academic achievement and functional performance. This is the big part. This is where now we've done this AAC assessment. This is where you're going to see a lot of that information now translated in here. If it's the year that you've done the device trials and gotten the device, a lot of that information is going to go right in this section, along with progress reports and things like that. The goals and objectives part. A lot of people struggle with this one, with what we write and how we write it. So there are tons of free and paid resources out there. The quad profile, the pragmatics profile, and the dynamic AAC goals grid, or the DAG, those are all free things that can be completed in order to determine goal areas for an AAC user. The AAC profile is something that is a paid resource, but it is a very good resource. I use that one for any child that comes into me that already has a device and they're questioning, is it the right device? So I will give that, and myself and the parent and maybe even the school team will complete that together and see where we think our AAC user is falling in all of the competencies in operational, linguistic, strategic, and social. Specially designed instruction. This is where we get to get lots of fun stuff in now. This or the things that tend to be left out, I guess. This is where I include the AAC prompt hierarchy, how they should be prompting. I do lots of trainings on these things too, and we'll get to that. Communication partner strategies, the availability of the AAC across all settings and environments. A lot of my families are currently struggling with this right now, that the AAC device is only out during speech and that's it. Or if the speech person comes in the room. Well, no, it needs to be available to them all day, every day. I just had this conversation with a special ed director earlier this evening about it needs to be available. You know, if you're going to be using low-tech communication boards, they need to mirror the student's AAC system. It is supposed to be treated as a second language. So if you have two different systems, one for the low-tech and one for the high-tech, that's not helpful. That's two different systems. That's probably why there's an increase in behaviors or device abandonment because they're not using it. Aided language stimulation goes into this part. The use of specified programs, like if you're going to be using Core Word of the Week, if you're going to be using Project Core, if you're going to be using Tell Me AAC, you would put that in here, that these are the types of things you're going to be using to support the use of the AAC device. This is also where people will sometimes list the device too. Now, many districts will not write it this way, that it says iPad mini with touch chat. You are supposed to dictate it more vaguely in case for some reason this touch chat is not available, that maybe you use something else. The way when you put it in here like this, it tends to, you have to use touch chat all the time. So if something happens to it, you're kind of in hot water. So many districts will not put this in like this, like saying exactly iPad mini with touch chat program provided by the district. I have seen program like provided by the district and that it's a dynamic display device with generative language, and color coding. All of that alludes to touch chat. So you're supposed to describe it in a way that it is, you're pretty sure it's that application, but then it's not being named specifically. That doesn't mean that your specific district will not put it in that way. Some do, but some are a little bit more hesitant to do that. That can differ based on districts. So, specially designed instruction continued. We talked about communication partner strategies. So this graph from assistive wear just shows what I mean by that. You know, that we're going to build good communication partner strategies by doing these things. We're going to provide wait time. We're going to attribute meaning to when they access the device. We're going to model. We're going to use strategies to respond to their communication. We might provide prompts or cues and kind of listing all those things. We need to support AAC users in a way that's specific and personal to them. You know, good communication partners listen and ask about how they can support the AAC user better. It's not the other way around. And it can take a long time to be proficient in an AAC device. This is why we do all of this work with the IEPs and trying to get as much information into the document as possible so that they can be supported. Because unfortunately, coming to speech twice a week for 30 minutes is not going to make them proficient AAC device users. It needs to be used all day, every day, across settings. And even at that ability, it can take years for them to become proficient. I have a kiddo now, and there's a little bit later on, but he's had his device for almost 3 years, and now he's in the last 6 months, he's gotten really, really good. He's doing inventive spelling. He's using a keyboard. You know, he's navigating the device. He's making sentences. He's doing phonics things. You know, these things took 2.5 years to do, though, with really consistent, rigorous therapy and support of the family and support of the school. It takes a village. The related services section, super important, and then tends to be the part that sometimes also gets overlooked the way it's written. So is it individual therapy? Are you recommending group therapy? Are you recommending consultative time? So I kind of have the best of both worlds. I work in an approved private school, and I have my own private practice. So all of my AAC users get individual therapy and group therapy and consultative time. They get all three. And it depends on their varying ability, what that looks like. You know, and that could be a push-in lesson in the classroom that ends up being the group therapy where I have a bunch of them at the table and we're doing an activity. Like these guys over on the left. This is actually a picture from our summer camp here, but you know, I might put the three of them at a table and we're going to do a group lesson together. And we're going to talk about things and we're going to do an activity. You know, there's definitely some individual therapy that needs to be done as well, because you need to teach them this system, and it's very hard to teach them that system in a group environment because we want them to be as proficient as possible. The bet as they get better, I tend to wean off of individual and move more towards group. The consultative time for my AAC users is always there, because there's always something I'm doing, something I'm making, someone I'm training, someone I'm calling. I'm always doing something. So they all have consultative time in their IEP as well. I also need time to program. I need time to set up a device because they're going on a pumpkin patch and I trip, and I want to make sure that they have things they can talk about for the pumpkin patch. Or one school, they do coffee cart things. as a life skill activity. So I want my AAC users to be able to do the greetings and, you know, asking the things that they have to sell and showing them all of that vocabulary. And if it's not in there, that I'm finding a way to put it in there for them that's easy for them to find. All of those things don't happen in a session. In a session, I'm actually teaching, I'm not programming. Support for school personnel. So this is where you're going to find your consultative time, but also something that's so very important is instruction and training for the staff and the families if they need it. I do my trainings twice a year. I do them once in the beginning and once following the winter break because we've all been lounging too much and having too many snacks. So we come back fresh from the new year, in the new year, and we kind of go through it again. My trainings range from an hour to 2 hours, depending on if it's the first or the second, and the topics differ. My first training is always on modeling and aided language stimulation, aided language input, whatever you want to call it. But modeling is the simple way to put it. And then we invite everybody. This is everybody. This is occupational therapy, physical therapy, the other speech therapists that may be working with the kid if they're sharing kiddos. This is all of the classroom staff. This is all my BCBAs, my RBTs, my paraprofessionals, everybody, occupation, everybody that I can get in that room all at one time, I do. I don't like when people aren't able to attend the trainings and then later on it turns into a whisper down the alley. Well, Kristin said this or Kristin said that. No, if we're all in the same room, everyone hears it at the exact same time and there's none of this whisper down the alley. I'm also able to model on my device. I project them up onto the screen. We have some the ability to Bluetooth like our laptops and things up into the TVs, and I'll put videos up for them. I will show them. I take videos of me working with the kids and I'll show them what I want them to do. I will come around to the classrooms as well and kind of jump in, be a fly on the wall if necessary. That's all encompassed in that consultative time as well. But I do list the trainings for the staff separately than the consult time. Oh, extended school year. So the majority of our kiddos that have AAC devices do tend to qualify for extended school year, especially because they do tend to regress when there's breaks and things like that. So we're tending to need to work on teaching things with the device, especially if it's not being carried over at home. We'll see that bigger regression. So I end up kind of going through things and making sure they all get their ESY time in order to kind of work on skills and keep their skills sharp. I'm not necessarily teaching brand new things, but I might be expanding on what they're doing. So maybe we were working on like 2-word combination. Maybe I'm going to push it a little bit. I'm going to try a couple 3-word combinations, or maybe I'm going to try to teach some grammatical markers or model that and see if they can pick on it. But I'm not going to teach anything like super brand new to them. I just want to make sure that they are retaining everything they learned from the school year. You know, and sometimes a lot of parents that I talk with, or even a lot of like supervisors of special ed, will come to me too from surrounding districts near where I am. Even when I was speaking with one today, and you know, they'll say like, I don't know if our program is the best for them. You know, some ESY programs tend to be more camp-based and kind of more lax. A lot of AAC users need a lot of explicit instruction. So sometimes those more lax environments does not promote them using their device as actively as it probably should. In which case they tend to come to me about our summer camp program. So we run a summer camp program within my clinic called the Everyone Deserves a Voice AAC Summer Camp. You know, a lot of school districts opt to use this as an alternative ESY program. in order to give them more explicit instruction with their device, but also paired with building their literacy skills as well, which are AAC users that are at a higher risk to not really learn to read and write. So we are doing a lot of those types of things here over the summer, and you can see we will teach them anywhere, in the window, on the crash pad, in the trampoline. You know, we have some kids with some flexible seating on the floor. My special education teacher is phenomenal with all of them, and you know, she gets to know all of them and they all love her. And you know, she does a really great job of taking all of what I put together as the speech therapist and implementing it as the special education. Which, you know, you don't necessarily have to settle for what is being offered. You can certainly look around and inquire about other programs that are around, you know, to see if that might be a better fit for an AAC user, to get more explicit instruction and practice on their device. Another thing that's nice about this is a lot of kiddos that I come into contact with, they tend to be the only kid maybe in their class, maybe even in their entire school, that has an AAC device. At our summer camp, they get to walk in and not be the only one. So they get that emotional tie to see someone else that's using a device and what they're doing. And depending on the level of the users, they're great models for each other. So questions. I feel like I talked fast, but.
All good. Thank you so much for that. And thank you for presenting. I'm going to end our recording with that, and we can start our Q&A. Thanks again for presenting.
Oh gosh, yeah, I think I talked fast. I'm sorry.
You're all
I was
good.
afraid I would run out of time, honestly.
Yes.
And I'll just put up my contact information too, in case anyone wants it or needs it.
Perfect. Thank you.